This is a mini lecture on pulmonary disorders. This is not an exhaustive list of conditions, but rather a review of common disorders. My name is Ruth Ann Skinner, and I'm an acute care nurse practitioner and educator. This PowerPoint was created in majority by Gail Tucker. Gail Tucker brings a vast amount of knowledge. Additionally, we have received feedback from Montana intensivist Dr. Dow. Let's start with COPD. There are two main forms of COPD, chronic bronchitis, which involves a long-term cough associated with excessive secretions, and emphysema, which involves damage to the lung over time and includes abnormal and permanent enlargement of the VLA. COPD is significantly related to tobacco smoking, although environmental exposures may also cause COPD. Spirometry is a recommended objective measurement of pulmonary function for diagnosis and management. Forced expiratory volume in 1 second, or FEV1, is the standard for COPD diagnosis. FEV over FVC will be less than 70%, and FEV1 and all other measurements of expiratory rhesus are reduced. Chronic bronchitis is defined as cough and excessive sputum production on most days for at least 3 months of the year for 2 consecutive years. As the irritated membrane becomes inflamed and hypertrophic, it narrows and shuts off the bronchioles, resulting in coughing spells that may be accompanied by phlegm and breathlessness. These patients have mild to moderate dyspnea. They have an onset of symptoms after the age of 35. Although their body habitus is stocky, they do not have a barrel chest. Diagnosis requires PFTs during non-exacerbation times. Hallmark of the disease is airflow limitation, less than 70% on PFTs, but normal total lung capacity. The ABG will show hypercapnia and hypoxemia. However, the patient will also have increase in the hematocrit. The chest X-ray will have bulba and bleeds. Emphysema is characterized by irreversible enlargement of the alveoli and loss of elastic recoil. Emphysema patients have constant dyspnea and are typically diagnosed after the age of 50. They have a thin, wasted appearance and will have an enlarged AP diameter. There will only be a small amount of sputum, which may be clear in color. Similar to chronic bronchitis, the patient will have an FEV over FVC ratio of less than 70%. However, their total lung capacity will be increased, and their DLCO will be decreased. DLCO stands for diffusing capacity of lungs for carbon monoxide. It determines how much oxygen travels from the villi of the lungs to the bloodstream. The ABG continues to show hypercapnia and increased bicarb, but the hematocrit will be normal. Generally, emphysema patients are CO2 retainers. It is helpful to know that they are retaining oxygen as their baseline. The chest X-ray shows expanded airways, flattened diaphragms, lucency in the chest X-ray. An exacerbation of emphysema demonstrates increased hypoxia, increased O2 demand, increased CO2 retention, and wheezing. The Global Initiative for Chronic Obstructive Lung Disease, or GOLD, evidence-based research guidelines for the treatment and management of COPD are the results of collaboration of worldwide leading experts in COPD and organizations that include the World Health Organization, the National Heart, Lung, and Blood Institute as well. The staging system established by these guidelines defines severity of stable COPD according to airflow limitations, and also guides management. The GOLD staging will determine recommended treatment plan. Chronic lung disease can be managed at home or in a long-term care facility with supplemental oxygen, bronchodilators, beta antagonists, long-acting anticholinergics, and inhaled steroids. It is important to remember long-acting inhaled beta antagonists, or LABA, are used for maintenance therapy. COPD exacerbations are characterized by wheezing, hypoxia, and hypercapnia beyond baseline. They may have a relatively normal pH on gas due to the chronic compensation by kidneys. There may also be an increasing oxygen and nebulizer use because it is not providing relief. Additionally, there is a change in sputum color, fever, and malaise. COPD exacerbations are most commonly caused by bronchial infections. Triggers can be most anything and include virus, bacteria, and others. Air trapping, also called gas trapping, is an abnormal retention of air into the lungs where it is difficult to exhale completely. Air trapping and hypercapnia should be monitored to evaluate success in your treatment. In fact, you should lower your O2 saturation goal parameters in these patients to avoid over-oxygenation. Treatments include IV and PO steroids, nebulizers, and antibiotics. Positive pressure in non-invasive ventilation or BiPAP helps decrease CO2 retention and can prevent intubation. Intubations may be required, however, it's very difficult to wean these patients off the ventilator. We will now discuss pulmonary embolism. Over 80% of all diagnoses can be obtained by history taking. When interviewing a patient with possible DVT or PE, the review systems should include the following pertinent positives and negatives: cancer, history of thrombosis, birth control, recent hospitalizations or immobilizations, pregnancy, and smoking. Signs and symptoms of pulmonary embolism include unexplained shortness of breath, problems breathing, chest pain, coughing, or coughing up blood. An arrhythmia may also be seen if there is a PE. Patients may also have this feeling of anxiety or dread, lightheadedness or fainting, rapid breathing, sweating, or an increased heart rate. Evaluate for signs and symptoms of a DVT, as sometimes this is the only indicator. These include swelling of the leg, along a vein or in the leg, pain or tenderness in that leg, a feeling of increased warmth in the area of the leg that's swollen or tender, and red or discolored skin on the infected leg. The Wells criteria risk stratifies patients for pulmonary embolism and has been validated in both inpatient and emergency settings. Its score is often used in conjunction with a D-dimer testing to evaluate for a PE. There must first be a clinical suspicion for PE in these patients. Wells can be used with either 3 tiers, low, moderate, or high, or 2 tiers, unlikely and likely. Wells criteria is not meant to diagnose PE, but to guide workup by predicting pretest probability of a PE and appropriate testing to rule out the diagnosis. An ABG will show hypoxia in 3/4 of all presentations. D-dimer is a protein found in the blood after a blood clot has broken down. This can be ordered to aid diagnosis of a PE, but be careful what you order. If you are suspicious of a PE, consider why are you ordering a D-dimer rather than proceeding with the definitive testing of a CT angiogram or a VQ scan. There can be many D-dimer false positives and can be associated with elevated creatinine. However, if the D-dimer is negative, there is no thrombus. An EKG will show nonspecific ST changes very common in PE. There may be bradycardia or tachycardia, but again, this is not specific to a PE. CTA of chest or a VQ scan are most commonly used for definitive diagnosis. CTA will show location and number of actual PEs. VQ scans are less specific and will result as a high, moderate, or low probability of a PE. Current guidelines for patients with acute PE recommend low molecular weight heparin over other types of anticoagulants. Patients on a heparin drip will be titrated based upon their PTT. Embolectomy is reasonable for patients with massive PEs who have contraindications to anticoagulation or who remain unstable after receiving fibrinolytics. If these procedures are not available locally, it is reasonable to consider transferring the patient to an institute with experience in these procedures. An IVC filter should not be considered for a patient with an acute PE. However, it should be considered if the patient has a known DVTs and cannot be anticoagulated prior to surgery. If a patient is hemodynamically stable, there is time to obtain a diagnosis prior to beginning treatment. However, if a patient is unstable, empiric anticoagulation will be administered. As always, you should evaluate the risk versus the benefit. Patient may be too unstable to go to a CTA. They may have renal failure, thus preventing the use of contrast with CTA. Often VQ scans are not available stat, and patients may be too unstable to leave the ED or the ICU. In this case, risk anticoagulation is examined. Interstitial lung disease. Interstitial lung disease includes a group of restricted lung diseases that have thickened or scarring that support tissues between the air sacs of the lung. This thickening can be due to a variety of causes, such as idiopathic, drug and medication related, genetic or hereditary, autoimmune, or simply unknown. The number of deaths associated with interstitial lung disease is very high and is similar to the breast cancer rates in the United States. The most common symptom of interstitial lung disease are dry cough and shortness of breath. The diagnosis of interstitial lung disease typically involves imaging tests, measurement of blood oxygen levels, and sometimes biopsies for tissue sampling. Some forms of interstitial lung disease lead to irreversible scarring and respiratory failure. Treatment is based on specific diseases, but can involve steroids to reduce inflammation. Sarcoidosis is the most common interstitial lung disease and can affect the whole body. Symptoms include progressive shortness of breath, which may be slow or rapid, as well as non-productive cough. Rales will be heard on auscultation. Diagnosing includes obtaining a chest x-ray characterized by the presence of non-caseating granulomas. Pulmonary function tests will show a restrictive defect. An ABG may demonstrate hypoxia as well as the disease progresses. CO2 retention indicates that the disease is very severe. Additionally, a tissue sample of the lung is safe and should be considered. Treatment aims at preventing disease, scarring, and eventual fibrosis of the lungs. Thus, steroids are common. Treatment also based upon symptoms affected and may include immunosuppressants to treat refractory pulmonary sarcoidosis. 90% of patients with sarcoidosis have pulmonary involvement. Staging of pulmonary disease based upon the chest x-ray allows a general prediction of outcome. For chronic sarcoidosis, there's a striking degree of diversity between patients. Some have persistent inflammation and others shift to a fibrolytic phenotype. Idiopathic pulmonary fibrosis is a clinical syndrome and considered the most common and the most lethal form of pulmonary fibrosis. It is more common in middle-aged or elderly men. The cause is unknown but is strongly related to cigarette smoking. Symptoms include progressive dyspnea on exertion, chronic dry cough, finger clubbing, chest pain, fatigue, malaise, and weight loss. Diagnosis is made with chest x-rays. In acute phases, you can actually see this ground glass opacities. Pulmonary function test results may be normal in mild or disease or show restrictive pattern. Similar to sarcoidosis, an ABG may demonstrate hypoxia and CO2 retention as the disease progresses. Prior to treatment, other causes must be ruled out. Treatment includes oxygen, steroids, and immunosuppressants, although data to support immunosuppression therapy for IPF is limited. IPF is usually a progressive illness and prognosis is poor over time. The only true treatment is a lung transplant. With continuing evidence-based research, providers can perform the best care with the best outcomes. Thank you for listening.